webinar. And we have some very distinguished speakers from all around the world who are being moderated by, again, two distinguished surgeons. And I have the pleasure of introducing Eva Botica from Croatia. She is the new president of the Croatian Society for Ambulatory Surgery. She is an ENT surgeon and a head and neck plastic surgeon also. At present, she is the head of the department of her university hospital. And her focus is mainly on pediatric surgery, pediatric ENT to be more specific. And we have with us Marc Olivier Sauvain. He is a professor and the president of the Swiss Society of Surgery. And he is a head of the thoracic surgery practicing in Switzerland. And with these words, I hand over to you, both the moderators. Best wishes.
Thank you, Naresh, for this introduction. And good afternoon, everyone, and welcome to this new session on the evolution and current state of ambulatory surgery across 3 different countries. 3 very different but equally instructive health systems: France, Hungary, and Japan. Ambulatory surgery has become one of the clearest markers of modern, efficient, and patient-centered surgical system. Yet the pace and the path of its development differ enormously from one country to another, shaped by reimbursement models, professional culture, and how each system organizes the patient pathway. And today, we have 3 speakers who will give us complementary perspectives on exactly that. So I leave the word to Eva to introduce our first speaker, Dr. Janos Meszaros from Hungary.
Thank you. So our first speaker is Janos Meszaros from Hungary. He will tell us something about the development of one-day surgery in Hungary. So the floor is yours.
Issues with Janos. So I will introduce you. Narahito Wada is from Japan. We will present the current status and challenges of the ambulatory surgery in that country. Dr. Wada is an associate professor in the Department of Medical Device Engineering at Kobe University. Japan offers a fascinating counterpoint, a health system under intense demographic pressure from a rapidly aging population, with a reimbursement structures quite different from the European model, and one-day surgery has followed its own distinctive trajectory. So we are happy to listen to you, Dr. Wada, and then we'll come back to you, Janos. Thank you.
Yes, I am here. Show you my presentation?
Yes.
Yes.
Okay. Can I begin?
Yes, please.
Okay. Hi, everybody. Good afternoon. My theme is the role of one-day surgery in the reduction of the waiting list in Hungary. My motto is today from Sir William Osler: the modern healing's aim, achieving maximum improvement in quality of life through minimally invasive interventions. Changes in one-day surgery cases volumes between 2010 and 2025. A steady linear increase in the number of day-case surgical procedures was observed through 2019. The impact of the COVID-19 pandemic caused a nearly 50% decline in the number of procedures in 2020 and 2021. It looks the healthcare system nearly 4 years to recover from this shock. It is evident that in 2025, the number of cases once again slightly exceeded the 2019 figures. The yearly trends of one-day case volume between 2010 and 2025. Year after year, we see a percentage increase in the number of cases compared to the previous year. Here, I would like to highlight the rate of this increase and the factors influencing it. These are as follow. First, quantitative and qualitative changes in professional regulations, increase in the number of same-day procedures, availability of acute care. Second, funding intensives. All same-day care procedures receive a 10% funding increase. Reported potentially reportable one-day surgery cases from 2010 to 2025. This figure illustrated the opportunities provided by the regulations and their implementation by the participating hospitals. It can be seen that the difference between the number of surgeries billed as same-day procedures and those actually performed on a same-day basis is steadily decreasing. The number of billed one-day cases has plateaued at approximately 80% of the potential number of cases, typically due to anesthesiological and surgical technical reasons. This ratio deteriorated in the 2024 and 2025. The reason for this is that the legislation enacted at the end of 2024 significantly expanded the scope of billable one-day procedures, while hospitals are responding to this with significant delays. The ratio of reported and potentially reportable one-day surgery cases. The number of one-day surgery cases by healthcare providers. The breakdown by type of healthcare provider clearly show that the volume of patient care provided by outpatient specialty care facilities and independent one-day surgical centers has remained essentially constant. It is also clear that the increase in the national case count is driven by the rise in the volume of one-day procedures performed at inpatient care facilities. Reimbursed day case encounters top 10 DRG changes 2023 and 2024. Top 10 procedures in Hungary. There has been a 4 increase in absolute numbers, but a shift within the field is evident due to technological advancements. The number of fecal emulsification procedures using standard intraocular lenses has decreased from 2000, a decline that is reflected in the increase in the number of phacoemulsification procedures using toric intraocular lenses. Case volume trends by DRG, the total day cases as percentage from 2010 to 2025. Waiting lists, interventions. The longest waiting lists: cataract surgery, tonsillectomy, adenectomy, sinus surgery, prosthesis mastoids operation, spinal stabilization surgery, spinal deformation surgery, spinal discus surgery, benign prostate operations, transurethral prostate operations, gynecological surgery and non-malignant operations, coronary interventions, cardiac electrophysiology, and radiofrequency ablation. There are 255 procedural waiting lists in Hungary. 39 interventions, it is 15% are on one-day surgery procedures. The total encounter between 2014 and 2025 as part of the waiting lists working out. Future tasks. First, strengthening cooperation by leveraging opportunities provided by international organizations and EU funding programs. Second, strengthening an independent professional organizational culture through the activities of the one-day surgery section of the Professional College of Healthcare. Third, in synergy with professional policy objectives, increase the volume of one-day surgical patient care, reduce waiting lists, and improve patient satisfaction. Thank you for your attention.
Thank you very much, Janos. Do you have any question for our colleague?
I have one question. Do you have any idea or plan of changes how to plan to reduce waiting list in the future?
In the future?
Yes.
Yes. We have...
this is problem for every country, so I just want to know your opinion about that.
Yes. We have two plane. One plane is it is my presentation. It was the financing condition is higher. Every operation is 10% higher, but another inpatient care situation, and we make a lot of operation in one-day surgery, and in the year 2024 we have 200 new operation in this type, one-day surgery, and so we can do, for example, in general surgeon operation, for example, laparoscopic cholecystectomy, and another operation we can do. Just a moment.
Okay, thank you. Other questions for Janos? I do have one question, Janos. I've read in the economics journal from Hungary that was in April 2026 that more than 43,000 cataract operations were performed within 6 months in Hungary. Mostly, as you said, as day surgery, but there were wide regional disparities, meaning that in certain areas you could be quite quickly be operated in Hungary, and in other area of Hungary you have to wait months to get operated in day surgery. And my question is, the national success is it masking deep territorial inequality in your country, meaning that only in certain areas you could get access to day surgery and in other absolutely not?
Mm-hmm.
Is it the case in Hungary or not?
It is little bit complicated question, but in Hungary is 4 university, medical university, and these universities are a lot of doctors in the clinic, but another place, for example, in county hospital or another hospital, the doctor's number is low, and it is the one problem. This is the first
Is
problem.
it that, or is it because when I look at your slide, you show us that most of the day surgery are performed in inpatient clinics?
Yes.
And you don't have a lot of dedicated day surgery clinics. Is it correct? Is it not that the problem? Because you are making day surgery within inpatient clinics. In Switzerland, for example, we know that when we do that, we lose a huge amount of money because the reimbursement is not good. And if I perform, let's say, hernia surgery in my hospital, I lose a lot of money. That's why we need dedicated clinics to be able to bridge this gap of reimbursement. And when I was looking at your slide, I was thinking that you've got university hospitals, and within the university hospital, you want to make all the outpatient day surgery, but you don't have the structures in different cities where you could have dedicated structures for day surgery. And I was wondering, how could you be, how can you make or perform those operations in a financial, on being financially well reimbursed?
It is not only not only financing question, but another side. It is the yes, as
the lack of doctors, you mean, of surgeons, of
yes, but in Hungary, the system function is the dedicated centers, and the dedicated centers can function in hospital and also in university.
Okay.
It's this center. These centers are from 2020, and in Hungary, the center's number year to year higher.
Okay.
And so we can the one-day surgery operations number year to year higher level.
Okay.
Right.
Thank you, Janos. I think we will move now to Professor Wada. I think you okay?
Yes, I'm okay. So I will try my presentation.
Thank you for the opportunity to speak today. My name is Narahito Wada, a junior surgeon, and together with Dr. Hiroki Imazu, the president of Japan Short Stay Surgery Association, I will be presenting on the current status and challenges of ambulatory surgery in Japan. Today, we would like to share our insights into how day surgery is evolving in our country, the unique hurdle we face, and what the future might hold. I have nothing to disclose. Let me begin by clarifying what we mean by ambulatory surgery in Japanese context. In Japan, ambulatory surgery is strictly defined by the National Health Insurance System as an event where admission, surgery, and discharge occur on the same calendar day. This evaluated under a specific reimbursement category known as the Short Stay Surgery Basic Fee 1. Historically, the Japanese healthcare system has been characterized by long hospital stays. However, our rapidly aging population and urgent need to contain medical costs have accelerated the shift toward outpatient models. This transition has been strongly supported by advancements in minimally invasive technique, and such as laparoscopic surgery and development of shorter-acting anesthetics. The aim of our presentation today is threefold. First, we will analyze the current clinical implementation of ambulatory surgery in Japan. Second, we will evaluate the profound impact of recent 2024 National Medical Fee Revision. Finally, we will identify the structural and cultural barriers that hinder its further expansion. To achieve this, we conducted a comprehensive review using Japanese National Medical Statistics, clinical guidelines for representative procedures, and the 2024 Medical Fee Revision documents issued by the Ministry of Health, Labor, and Welfare. We also utilize OECD health statistics to provide an international perspective. Looking at the current clinical implementation, standardization is most advanced in ophthalmology, particularly for cataract surgery and general surgery. Inguinal hernia repair is a prime example. The Japanese clinical guidelines recognize day surgery for inguinal hernia as a highly evidenced standard option. The wide adoption of laparoscopic techniques has been a game changer because laparoscopic approaches significantly reduce post-operative pain compared to open surgery. patients can mobilize earlier and return home safely on the same day. This has led to the establishment of specialized day surgery clinics across the nation. Clinical success is only one part of the equation. The patient's perspective is equally important. Studies in Japan show a high satisfaction rate of approximately 83% among day surgery patients. They appreciate being able to relax in their own homes, experiencing less disruption to their daily lives, and facing a reduced economic burden. However, this high satisfaction is contrasted by significant preoperative anxiety. Patients often express strong fears, not only about the surgery itself, but also asking, is it really safe for me to go home today? Interestingly, this anxiety drops dramatically once they are safe home. This highlights that technical excellence alone is not enough. Rigorous post-operative home care instructions and continuous mental support are absolutely vital for success of ambulatory surgery. Now we arrived at the first major challenge, which is the core of our presentation, the 2024 medical fee revision. For the day surgery sector in Japan, this revision was a massive shock. The government drastically halved the reimbursement points for the short stay surgery basic fee 1. To give you specific numbers, for the day surgery involving anesthesia, the fee dropped from 1,588 points down to just 795 points. For cases without anesthesia, it dropped from 1,359 to 680 points. While the government's intention might be to reflect the efficiency of these procedures, for specialized clinics that focused entirely on day surgery, this 50% cut poses a severe financial threat to their survival. Because of these drastic cuts, specialized clinics now face a struggle for sustainability. As Dr. Ima's experience shows, day surgery clinics must perform a very high volume of cases just to keep their business viable. In response, professional organizations like Japan Hernia Society and Japan Short Stay Surgery Association have been actively advocating and lobbying the Ministry of Health, Labor and Welfare to increase the base points, particularly for the procedures like laparoscopic hernia repair. However, the reality of these negotiations is tough. The Ministry relies heavily on existing medical claim data to make the decisions. Therefore, to prove the value and the necessity of better reimbursement, the medical community must continuously increase the proportion of day surgery actually performed and recorded in national data. Our second major challenge is cultural and structural one, Japan's persistent impatient culture. When we look at the international comparisons, the discrepancy is striking. According to 2022 OECD data, the average hospital stay in Japan is 27.3 days, whereas the OECD average is only 9.7 days. There are a deeply rooted belief among both patients and medical providers that surgery is inherently requires hospitalization and bed rest. This cultural barrier makes it difficult to expand day surgery. Furthermore, there is a very real risk of what we call reverse incentives. If day surgery is financially penalized by halved fee we just discussed, hospitals and clinics might simply shift patients back to short-stay admissions, such as a one-night or two-night stay evaluated under Basic P3, just to maintain their profitability. These financial and cultural barriers directly impact operations. Running a day surgery clinic safely requires multi-layered safety measures. Because patients go home the same day, clinics must have redundant surgical equipment, such as backup laparoscopic systems or electrosurgical units, to prevent any intraoperative delays. They also need strict patient selection criteria and 24-hour follow-up protocols. The ultimate dilemma facing Japanese ambulatory surgeons today is this: how we maintain these exceptionally high safety standards, which are costly, while operating under a reimbursement rate that has just been cut in half. In conclusion, ambulatory surgery in Japan, especially in fields of general surgery, is at critical turning point. While our clinical and technical safety standards are remarkably high, the sustainability of this model is under severe threat from recent reimbursement cuts and our traditional inpatient culture. To overcome these barriers, we must optimize regional medical networks, clarifying which patients are suitable for day surgery and which require admission. Furthermore, integrating digital health technologies such as wearable remote monitoring and AI will be key to ensuring patient safety and confidence at home. Redefining the true value of ambulatory surgery is no longer just an option. It is an absolute necessity for the sustainability of healthcare in Japan's super-aging society. Thank you for your attention. I'm happy to discuss with you.
Thank you for your presentation. Do you have any questions to Professor Wada? So I do have a question. You showed the data of the OECD. Japan is one of the leaders of the number of beds in hospitals in the world, and also for the length of stay of patient after surgery. And if I understood correctly, they decrease the amount of money you will receive to do day surgery. Is it correct? So how do you think in the future you will be able to make the shift of inpatient to outpatient with those political incentives? How would you get out those huge amount of money you spend in your health expenditures? It's about 48 trillion yens that you spend. So it's a huge amount that you spend in your health system. And it looks like to me that they're not spending a lot of money to create good incentive to perform outpatient surgeries. What is your opinion on that?
Yeah, it's true that the Japanese government cannot understand the merit of day surgery. So our continuing advocacy is essential to improve our situation.
So you're expecting that it's going to stay like that for a couple of years, where you will continue to perform inpatient surgery and not ambulatory surgery. Are you pessimistic for the future of ambulatory surgery in Japan?
Yes. Of course, we are doing many things to improve this situation, but it's very difficult. It's a tough negotiation. for us.
Any further questions from the audience? Do you have one? What kind of do you have surgeries that you have to perform on an outpatient setting or within an outpatient setting? Is it compulsory to do some surgery in Japan in outpatient setting, or the doctor can choose what he will do?
Oh, it's a very important point. Of course, the hernia surgery should be done under the outpatient setting. The truth. So,
but who decides, the surgeon or the state?
I think the the inpatient surgery is reimbursed for. It's so the surgeon have to contribute to our hospital to earn much more money.
So it means that the surgeon decides, because of financial aspect, you will do that in patients. Because, you know, in Switzerland, the state decided for some surgeries that we have to do or to perform those surgeries in an outpatient setting. And if we don't have the politicians saying, okay, guys, you have to do that, we would continue to probably to do it in an inpatient setting until the whole system collapses. And we are experiencing that in Switzerland now, where we have to do or to perform some surgeries in an ambulatory setting. Otherwise, we won't get reimbursed. But if the incentive is perform your surgery within the inpatient setting, it's going to be very difficult to develop outpatient or the ambulatory surgery in this country.
Mm-hmm.
I don't know if other people have any questions for our speakers, because I'm not seeing Christelle Galvez and Naresh.
Yes, she has not responded. So I think this is the end of the 5th webinar, and I take this opportunity to thank my moderators, Eva and Marc Olivier, also my speakers, Janos and Narahito. This will be edited and put on the IAAS channel to be circulated for everybody to see forever. And then we move on to the 6th webinar, which is on the 29th of August. Till then, thank you very much once again for coming together, and see you. Bye-bye.
Thank you. Bye.